Bismillahirrahmanirrahim. Quote of the day. Take care of your thoughts when you are alone and take care of your words when you are with people. Today, the topic of presentation is Leishmaniasis. The learning outline of my presentation is burden of disease, epidemiological triad, level of prevention, and recent advances. In the end of presentation, participant will able to describe about leishmaniasis infection, burden of disease, and recent advances. Introduction. 1900, Sir William Leishman discovered L. Dunovani in spleen smear of soldier. Then Charles Dunovan also recognized these symptoms in other patients. After examining the parasite using Leishman stain, these A. mastigores were known as Leishman-Dunovan bodies. Leishmaniasis is globally important but neglected disease affecting approximately 1 billion people every year. It is more prevalent in Europe, Africa, Asia, and Latin America. This slide shows the neglected tropical disease list. Previously neglected disease are TB, HIV, AIDS, malaria, but now soil transmitted helminths, schistosomiasis, lymphatic filariasis, onchocerciasis, leprosy, trachoma, leishmaniasis, Burley ulcer, Chagas disease, dengue, cysticercosis, echinococcus anthrax, brucellus, rabies, these all are neglected tropical disease. Burden of disease. The leishmaniasis are a group of disease caused by a protozoan parasite from more than 20 Leishmania species. These parasites are transmitted to humans by the bite of an infected female phlebotomine sandfly, a tiny 2 to 3 mm insect vector. There are three main forms of this disease: cutaneous leishmaniasis, visceral, which is also known as Kala-Azar, and mucocutaneous leishmaniasis. In 2018, 92 and 83 countries or territories were considered endemic or had previously reported case of cutaneous leishmaniasis and visceral leishmaniasis, respectively. There are three types of leishmaniasis: cutaneous, visceral, and mucosal. Visceral are also known as Kala-Azar. Now comes the epidemiological triad, and we discuss three factors: environment, agent, and host factor. First, we discuss agent factor. Leishmania are intracellular parasite and Leishmania donomini causative agent for Kala-Azar, Leishmania tropica causative agent for cutaneous leishmaniasis, and Leishmaniasis brasiliensis causative agent for mucocutaneous leishmaniasis. Now comes the host factor. All ages are susceptible to this disease. It is present in both sexes but more prevalent in male. Recovery from Kala-Azar and oriental sore give long-lasting immunity. Movement of migrants, laborers, and tourists from endemic to non-endemic area cause the spread of this disease, and poor housing and poor domestic sanitary condition are responsible for the spread of this disease. Diet which lack in protein, energy, iron, vitamin A, and zinc also cause the disease. In environmental factor, it is mostly confined in plain areas, high prevalence during and after rain. Disease is confined to rural areas. Sandflies mostly breed in cracks, surfaces in soil, tree, holes, and cave. Now the mode of transmission. It is transmitted from person to person by the bite of a female phlebotomine sandfly. After an infective blood meal, the sandfly become infective in 4 to 25 days. Extrinsic incubation period. Incubation period in man is quite variable, approximately 1 to 4 months. Reservoir. Man is the only reservoir of Kala-Azar. Case detection and treatment may be sufficient to abolish the human reservoir. And animal reservoir includes dog, rodents. Extensive dog and rodent control programs contribute greatly in reduction. Now we discuss the life cycle of Leishmaniasis. Leishmaniasis is transmitted by the bite of infected female phlebotomine sandfly. The sandfly inject the infective stage promastigord from their probus during blood meal. Promastigord that reach the punctured wound are phagocytosed by macrophages and other type of mononuclear phagocytic cell. Promastigod transform in these cells into the tissue stage of parasite, which is known as amastigod, which multiply by simple division and proceed to infect other mononuclear phagocytic cell. Then parasite, host, and other factor affect whether the infection becomes symptomatic, cutaneous, or visceral. Then sandfly comes and it ingests the infected blood during meals. And then these amastigod again transform into promastigod in the gut of the sandflies. And the cycle goes on. This is the diagrammatic representation of the life cycle of leishmaniasis. Sandfly stage, and this is the human stage when promastigods are phagocytosed, then promastigod transform into amastigod, amastigod multiply, and then sandfly bite the infected meal, and then it again transform into promastigod in the gut of the sandfly, and again sandfly bite the human. Clinical feature: hepatosplenomegaly, night sweat, multiple episode of fever that last for a week, bleeding, blackening of skin, scaly skin, cough, and substantial weight loss. These all are the clinical feature of visceral leishmaniasis. In cutaneous leishmaniasis, mostly lesions are present on the skin around the bite of sandfly. It is mostly present on legs, arms, and face. In mucocutaneous leishmaniasis, lesions are present around the face and pharynx. Now comes the level of prevention. In primary level of prevention, there is health promotion and specific protection. In health promotion aspect, we avoid sleeping on floor, educate the people using insect repellents, using fine mesh net around the beds, or and keep the environment clean. There are no as such specific protection because there are no vaccine available for this disease. What are the possibilities and challenges for developing a successful vaccine for leishmaniasis? There is an urgent need for developing a safe, effective, and affordable vaccine for the prevention of leishmaniasis. Although in recent years, a large body of researchers has concentrated their effort on this issue, but only 3 vaccine candidates have gone for clinical trial until date. These are kill vaccine in Brazil, live attenuated vaccine for humans in Uzbekistan, and second generation vaccine for dog prophylaxis in Brazil. But there is no as such vaccine available for this disease. These all are vaccines which are under trial phases. Now come the secondary level of prevention, and in secondary level of prevention, we early diagnose the disease and prompt treatment. And how we early diagnose this disease? There are a multiple diagnostic tests which are available for the diagnosis of leishmaniasis. First, we do microscopy based on visualization of a mastigod with Giemsa or stain upon microscope, examination of tissue specimen. Promastigod can be grown in a biphasic medium using a blood agar-based inoculation of mice, can also result in parasite isolation. Leishmania skin test, which measure delay type hypersensitivity to antigen of the parasite. This is used for the diagnosis of cutaneous leishmaniasis. And antibody detection, this test is mainly used for visceral leishmaniasis. The most commonly used technique are ELISA, based on recombinant antigen, mainly RK39 for visceral leishmaniasis. For cutaneous leishmaniasis, ELISA and Western blot are used. And in molecular diagnosis, DNA amplification of PCR, the most commonly used technique for detecting and using PCR test. Treatment. And for the treatment purpose, liposomal amphotericin B, IV single dose, 10 mg per kg, combination regime, multifocine capsule plus paramomycin injection IM, and amphotericin B emulsion is used for cutaneous leishmaniasis. What are the stats of epidemiology of cutaneous leishmaniasis in Pakistan? Cutaneous leishmaniasis is very prevalent in Pakistan. It is endemic in Balochistan, interior Sindh, Multan, and KPK. The bell-bottom sandfly vectors in Pakistan are Leishmaniasis tropica, bell-bottomine sargenti, bell-bottomine sally, bell-bottomine papatasi. These all are vectors of sandfly which are present in Pakistan. Leishmaniasis outbreak and response. There have been sporadic cases of leishmaniasis throughout the province, with recent outbreak in Karak, Bannu, Charsada, Mardan, Shangla, and some other districts. Positive organism is phlebotomous hepatocide sandfly. The vector is a fly called sandfly but is found in almost all districts and throughout the year. Although necessary measures are response are being taken, yet hundreds of cases go unnoticed due to late health seeking. Lack of surveillance system and frequency of disease in remote areas and native population means that it is difficult to estimate the true incidence of leishmaniasis and the case fatality of visceral leishmaniasis. Outbreak and response. Leishmaniasis is a vector-borne disease with a variety of parasite species, reservoir, and vector involved in its transmission. Provincial Leishmaniasis Control Center at Peshawar, looking at the importance, variety, and incidence of outbreak. Government Nasirullah Khan Babar Memorial Hospital, Peshawar, on the direction of Health Department, started a cutaneous leishmaniasis project in collaboration with France during May 2018, with the intention that it will be a provincial center to provide health service to leishmaniasis patients from Peshawar and other districts of province include Exparta. Step taken by the department has declared leishmaniasis is a notifiable disease under Public Health Act. Guidelines for prevention and control of leishmaniasis have been circulated. Drug Registration Agency Pakistan has been requested to register the relevant drug. WHO was requested to provide the drug which has been provided as requested, but the quantity is not sufficient for treatment. A Leishmaniasis Management Center is established at Nasirullah Babar Hospital, Peshawar, which is operational since May 2018. This center is providing medicine to all the patients free of cost. This is the whole summary of Leishmaniasis. It is a disease caused by an intracellular protozoan parasite. Cutaneous, visceral, and mucosal leishmaniasis are three forms. Painless chronic lesion around from nodules to large ulcer. In visceral, there is a irregular fever, hepatosplenomegaly, and pancytopenia. Ulcer in the mouth, bleeding, and runny nose. Risk factor: poor socioeconomic condition, immunocompromised patient. There are three types: cutaneous leishmaniasis, visceral, and mucosal. Diagnoses are done by light microscopy, antibody titer, skin testing, and culture. These are the references of my presentation. Now comes the MCQ session. Arthropods which prefer to suck the blood of human being are called zoophilic, anthrophilic, exophilic, endophilic. Correct answer is B, anthrophilic. Most prevalent form of leishmania in Pakistan is L. tropical. L. tropical. L. tropical. Phlebotomous hepatacea act as a vector of leishmaniasis. The most important reservoir of leishmaniasis is dog. Case of acute visceral leishmaniasis.
C.
B. B is correct answer. Case of acute visceral leishmaniasis. Man is the only reservoir. Patient presented in OPD with complaint of fever, cough. On examination. There is a finding of hepatosplenomegaly and lymphadenopathy. The most likely diagnosis is for cutaneous leishmaniasis. The main diagnostic test is correct answer. Antibody titer and PCR and microscopy are used for the diagnosis of other form of disease. Which of the following is neglected tropical diseases? Trachoma. Right answer. Trachoma. In life cycle of leishmaniasis, the infective human stage are started when promastigot and phagocytose.
B.
A is correct answer. Infective human stage are started when promastigotes are phagocytosed. Leishmaniasis kit test for CL shown which type of hypersensitivity reaction? Type 4, delay hypersensitivity. There are multiple vaccines in experimental phase. How many goes for clinical trial? 3 vaccines. E of the MCQs. Thank you.